Good afternoon and welcome to another episode of Ask the Doctors on Whitewater Community Television, WGTV Channel 11, WCTV Channel 21, and streaming live on Facebook. If you have a question, ask it on WCTV's Facebook page or send a tweet to WCTV Info. Thanks to John and the staff at CTV3 in Connorsville for airing this show. I'm your host, Dave Jetmore. I'm sitting in for Eric Marsh, who will be joining us again in 2 weeks. Our guests today are Dr. Thomas Youth, VP of Medical Affairs at Reed Health, and Christine Stinson, Executive Director of the Wayne County Health Department. Welcome, and I think we're going to have a great show today. Well, as we always start every Friday, we look back over what's happened in the rapidly changing world of COVID in this historic pandemic. Tom, why don't you bring us up to date on what's been happening in the world, in the United States, and of course in Indiana?
Could certainly do that. And Ryan and Stephen, if you're able to show maybe the Johns Hopkins COVID tracker, which is kind of the many trackers, the one that I typically go to. But basically what we see is on the world stage, and down in the lower right portion of that, guys, there's a little tab at the very bottom on the right that says I think daily cases or cases by day. That's the one. And if you can enlarge that, you know, we can see that in the world we have a steady upgrowth. And I ordinarily draw a trend line along the lows, and we can see that we have a continuing succession of higher lows and higher highs in the world, and then you can minimize that again. And the world is up to over 17 million cases now. But if we highlight the U.S. line there, the daily cases will change in the bottom, and if you will maximize that again, guys, we can see that the U.S. is actually kind of in something of a plateau lately. Now, where it goes from here in the entirety of the U.S. is anybody's guess. We have recently had increases, a lot of increases in the 4 or 5 key states that I've been following for at least the last month. You know, Texas, Florida, California, Arizona, and in the last couple of weeks, Georgia came into the Big Five. They account for the majority, at least 2/3 of the cases in the U.S., or have done over the last couple months. But they have all kind of plateaued out, which is why the U.S. looks the way it does. And the states that are beginning to trend upwards are places like Illinois, Pennsylvania, some others that had a big peak in the spring, and they're trending upwards slightly now. So, you know, what happens overall, we'll just have to wait and find out. I'm hopeful that things will trend down generally across the country. That may not be the case. We'll just have to see. If you want to switch over to the Indiana app, guys, and scroll down there, they've changed the way that the app looks and works a little bit, but down what's now at the lower right is the daily cases in Indiana, and we can see that, and we can't enlarge that particularly, but we can see that those have plateaued a little bit as well in Indiana, which is good. And if you click on the deaths tab on that metrics by day, we can see that the deaths continue to be low, although 2 days ago there was a rather high number of deaths. I think that's 17 compared to what it's been over the last couple of months. Hopefully that does not mean there's a new trend developing in the deaths department, because we've had this disconnection between the case growth and the deaths for the last 2 to 3 months, which is kind of interesting and welcome, but we don't want to see the deaths increasing significantly. So that's
And
where we're
why
at.
do you think that is, Tom? Do you think it's because younger people are getting
Yes,
infected
there's no
and they're
question.
not as
Well,
likely to have mortality as our older
You're
people?
right, and I think that there are many contributors to it. The deaths are certainly, or the age group shifts are a part of it, and I brought an exhibit today that we can look at now or we can look at later. Or maybe it's convenient to do now, Ryan, if you can show that. I sent you about a 4-page PDF.
Yeah.
The last page of it is the age groups. And what we have here is the lighter bar are the during the weeks prior to and up to about May the 16th. And this is the cases by age group. And we can see that prior to the middle of May, the largest number of cases were in the higher age groups. The darker bars are the age spread after May the 16th. And we can see that that has shifted, really, in my mind, pretty dramatically to the lower age groups, particularly the 20 to 50 or so age range. And that's what we're seeing in Wayne County with the age distributions. And as you were pointing out, we know that the illness tends to have lower severity in the younger age groups. But we are still seeing significant cases in the higher age groups. But I think, so you have to ask the question, what's behind that age shift? Some people suppose that there may be changes to the virus, genetic changes, mutations that may make it more infectious in younger age group compared to old. I don't know, that's very speculative, but could be the case. But one thing that Christine pointed out on a call one of the regular calls that we have is that, we have been doing a lot better job lately of protecting those who are in the older and more at-risk age groups. As an example, we're much more aggressive about protecting people that are in long-term care facilities who are most at risk. And when there's a lot of long-term care cases, that's when the deaths really dramatically rise.
Well, and I think it's important to look locally at what's going on in Wayne County. We had very little community spread in the early stages of COVID, and I think that it was because we did jump out early with certain closing down of certain businesses like beauty salons and things like that helped keep our community spread down. But then as we kind of started to lift things up and expand, and start moving back around, we now have a lot of community spread. We had very little deaths in nursing homes early on, but in the last 10 days, we've had 3 deaths in Wayne County. And I think that that's important to remember, that the more community spread that we have, the more our elderly are at risk.
What's happening in Wayne County right now as far as the infection rate?
Right.
The document that I sent you guys is there. It's the first few pages, if you want to pull that up, Ryan and Stephen.
And I do think the graphic for Wayne County tells the story. You see a very sharp increase in cases shortly after the 4th of July. And so I think that we did see a bump at the 4th of July, but now we're just seeing exponential growth.
Yeah, you can see it on this graph. It's pretty dramatic.
Right. It is very dramatic. We are, just like Dr. Huth talked about, seeing it in all age ranges. We see, when we do the case investigation, I think that that's interesting to talk to people and have them try to tell us, where do you think that you contracted the disease? And we've been able to trace it down to one outbreak was at a bar, and that was over the 4th of July. Several of them became sick after that event, and then it's like a spider web, where you have that central spin, and then it offshoots, and you have another central spin here, and then another one here, and another one there.
I think we're going to pivot right at this point to our guest, who is Jared Dunlap, the Director of Inpatient Nursing, and we're extremely happy to have him here. He's been waiting in the Zoom room, which is a virtual room. We have a bowl of virtual M&Ms for him and a glass of virtual wine in that room.
Really? I want to be in that room.
Welcome, Jared. Thanks
that.
for joining us. I can't quite hear you yet. Ryan's going to have to work on your audio.
Well, while they're fixing that, I would mention we have been seeing increasing cases at Reed. We've highlighted that in recent weeks. The graphics are there on the document that I sent. If we can show those, fine. If not, that's fine too. And we continue to see some increase. That just kind of is the end of the chain from the transmission, sort of thinking about the increases at the state level, the county level, and at the local health system level. Fortunately, we've had very few ventilator patients, even though we've had increased numbers of COVID patients in the hospital, and that may be an indicator of lower severity overall.
And those are good.
Ready to go with,
All right.
with
Are we
Jared?
ready for Jared, Ryan? There he is.
Hello, Jared. Say hello so we know you're there. Are you muted on your end, Jared?
Well, we've got an ace technical crew working on this, Jared.
Well, when we're talking about Wayne County, when we look at our positivity rate, early in the month, our positivity rate before July 4th was right around 4.5%. Today, it's at 10%, our positivity rate. So along with our cases increasing, we can tie that to increased testing, which we are doing increased testing. But that positivity rate shows that we are seeing more cases, not just from more testing, but our positivity rate has also taken a sharp tick up.
Well, we know when the state came in and just randomly tested the county, the infection rate was about 3%. That was back in May when they did that initial test.
And then they did the second round was in June. And then there'll be another, the phase 3 starts in October.
Yeah, they published the results of the first phase recently in a Morbidity and Mortality Weekly Report from the CDC. And I like the write-up that was there. It gives a little more definition than what they had published previously. But they mentioned in there that they think that we are possibly undercounting cases by about a factor of 10. Somewhere between 6 and 24, and they kind of picked a 10 in the middle of it. And so I think that's important to recognize that we're detecting increased cases, but how many more cases are out there?
Can you hear me now?
There we go.
Gotcha.
Yeah.
All right, there we go.
Well, we'd rather have
Welcome,
the
Jared.
audio than the video, but we've got both, so that's great. Thanks for being there, Jared, and I thought it would be fun to speak with you a little bit because you have a kind of a unique perspective on this whole COVID thing because you're the director of inpatient nursing at Reed. You're the first non-doctor that we've talked to, other than Christine. We've had Christine on Zoom and some school administrators, but you're the first non-physician healthcare person. But you're a leader in the nursing department, and that really, for those of us who've been around hospitals, we know that the nurses really kind of run the hospital, not so much the doctors. And I thought it'd be fun to start with a conversation with you, Jared, about taking your mind back to the very beginning of COVID, when we knew it was out there in the world, in China, and that there were beginning to be a few cases in the U.S., and then it sort of seems like there was a clap of thunder out of the blue that we've got it in Wayne County, and we were seeing admissions for it and so forth, and we had to kind of pivot almost overnight to being able to take care of these patients. Tell us about what that was like and what kind of things you had to do on short notice to be ready to take care of these patients.
Yeah, so we were watching this disease come across the nation a little bit, and one of the things that as we were watching it and we've seen it spread when it first kind of hit here in Wayne County, we had to quickly flip a switch and try to figure out, get the PPE ready, get our staff prepared, do some, make sure our staff had the education appropriately of what they needed to do to actually care for these patients, and also designate some units to where these patients were going to go. And we quickly got together, put some great minds together and worked as a team and figured out the process and flow of how we're going to move these patients, where they're going to go, who's going to care for them, how we're going to wear our protective equipment, keep staff protected, and keep the patients safe as well too. So it was a quick flip switch overnight, as you say. But yeah, it was a lot of fun, I would say, but it's also a little nerve-wracking. And I think, but working with the physicians and doctors and even our OC Health and EVS team, everyone pitched in and worked together really well.
And I recall that, it took a lot of effort to come up with what exactly we were going to do and what was the evidence for the specific interventions we placed. And there was a lot of training to what we decided the PPE standards would be. And you mentioned nerve-wracking. What was that like from a psychological standpoint for the nurses particularly and other clinical staff to transition into how to take care of these patients?
Yeah, I would say, at the beginning, we didn't know how many patients we'd actually see. And I think when we started seeing some, and all of a sudden they were kind of coming in, like by the hour, we had like 4 or 5 right away. I think it took us a little off guard. And so we decided to change up our process right in the moment and say we're just going to train all nursing and get them all through the training of how to protect themselves and protect the patients as well. So that took a lot of effort overnight. We had people coming in throughout the night trying to train all nurses. We had nurses coming in off shift just to get training. I would say the nurses did a great job, wonderful job, actually, just trying to say, this is here. We got to do what we got to do to help care for our patients. And I would say I was very proud and impressed of how well they just they kind of put the scrubs on, you say, and just kind of went in and did what they had to do to help care for patients.
So by now, I imagine most everybody's got a really high degree of confidence in their ability to function in that environment. And but it is a challenge. What is it like actually functioning in a COVID isolation area with the extra protections, the PPE and so forth? How is that different, and what are the challenges associated with doing that?
It is challenging. It's a lot more. We have to wear the N95 mask, the face shields as well, and wearing an isolation gown and gloves almost 90% of the time you're at work. So it does add a lot more stress physically to the staff, and breathing with the N95 is a little more difficult, but it has offered the highest level of protection for our staff as well and for our patients. So the staff feel really secure with wearing that as well, but it does add that physical stress onto the staff. And I would say just adding more challenges. The simple things aren't so simple anymore. As taking a patient down to X-ray is sometimes a little more challenging now, because trying to make sure we go down the right paths of trying to, if they're COVID, going down the right elevator to take them to the X-ray to radiology and bringing them back. So that way we keep our patients as much separated as possible to minimize the risk of the spread of COVID, and also cleaning everything off that we touch. We're constantly cleaning, wiping things down that we normally would just do on a regular basis. Now we're doing it almost quite often, every hour almost, as we're wiping things down so we can continue to reduce that risk of spread of COVID.
Would you say that the measures, the protection is effective? I mean, that might sound like a silly question, but I think people that maybe want to hear about how effective it is. For instance, have we had cases of COVID amongst staff acquired from patients, to your knowledge? And what do the nurses have a high degree of confidence that they are protected when they're in that environment?
I get the hear from the staff often daily, and they always say that they do feel very protected. They feel like the PPE that we are using is at the the highest level of protection for them, so they actually feel safe and secure with what we are offering them. And Reed did a really great job of always having the PPE that we needed all the time. We had a great supply of it, and our material services did a great job of always securing and making sure we always had enough. But I would say that that I would say that safety-wise, I think I feel highly comfortable that our patients and staff are super safe with what we offer, because N95 masks are the best protection we offer, and we also have helmets that they can wear if they absolutely need to as well.
Now, you mentioned patient safety in there. You use those words, and I know, as you do, that in the isolation areas there are patients who go in there who are known or very highly suspected to be positive, and they will ultimately turn out to be. But there are also patients who spend some time in the isolation areas because they're sort of under investigation initially. It's not initially exactly clear what their issues are, if they're having respiratory issues that can be due to multiple things. But they may be investigated for COVID-19, and that's where they reside temporarily. But then they get kind of ruled out and move on. I think, from some people's perspective, it's important to know about what protections do you have in place in those areas to prevent cross-contamination from the actual COVID patients to those who are not COVID and rule out. What do we do to protect them?
Yeah, so we create a process of, we try to group our patients together that we are ruling out or suspected of COVID or have COVID. And as they're in these containment areas, the nurses are always wearing protection from one room to another room. Can you hear me?
We hear you.
Sorry. They wear protection from one room to another room, and they take that off and garb up a new one, so that way they keep each other safe. And then I would say that the patients, as we always take the route that we think they have COVID, we're going to wear the highest level of protection that we can to protect us and protect them. And then when we rule them out, then we'd actually move them out of those containment areas to a non-COVID area where they can wear the surgical mask. The staff will, and the patients actually will wear a surgical mask as well to help prevent that prevention, highest level of prevention between them and us as well.
Jared, before we let you go, do you have any questions for Jared?
Hi,
Christine?
Jared. Nice to meet you. I was just
Nice to meet
wondering if things have changed as we went through since March when we started to see our first patients to now. How has the treatment for COVID changed at Reed Hospital?
I would say if anything, it's getting probably better. We're kind of reacting a little quicker as patients their condition changes. Our physicians actually did a great job of gathering research and data, and we were looking at some of the best practices that were out there that we can actually look at, and they're combined with nurses and physicians. We're coming together to actually put in place protocols and processes to help improve our patients and give them the best care they can. And as we continue to go on, we keep evaluating those processes and keep looking at the protocols as we to make sure that what our patients need. But I would say the care is we get more aggressive with the care as we see these patients come in. We can kind of almost spot them now when they come in, and we try to do the highest level of care we can give them at the beginning, because if we can be more aggressive with it, we notice that they do a lot better on and they recover quicker.
Jared, Ryan talked into my ear here and told me that we had a question from one of our viewers asking if any Reed employee had gotten infected in the hospital from a patient.
Yeah, so I forgot that as Dr. Hughes answered that. I kind of didn't get that question answered. But no, we actually not any of our nursing or staff has actually taken care of COVID patients have not gotten sick from those patients, or nothing, not to my knowledge. And we do track that really closely with our OC Health does that, and that's solely what they're doing every day. But no one I'm aware of actually got sick from that.
All right. Well, thank you so much, Jared, for spending some time with
much.
us today. Thank you so much.
Thank you for having me.
All right, now I think we're ready to turn to some questions from our Facebook page. Ryan, do you have the first question? If you get an antibody test and the results show that you have had COVID-19, does that count as a COVID case? Who wants to take that question? I can see both of you leaning forward.
I can tell you what I think it is, and you tell me, Christine, if I'm correct.
I want to know what you think it is.
I think that the answer is, if to add, maybe we need a little more specificity on the question, does it count as a COVID case as far as the state is concerned, like for reporting purposes? And to my knowledge, antibody test positives are not reportable to the state.
Correct.
So by definition, they don't go into the state statistics.
Correct.
There are actually two forms of testing that do. There's the nasal swab test that's called the PCR test. That's we're all familiar with. Those definitely do. But there is a new form of testing for antigens. That's different from antibodies. That is probably going to be more commercially available. And for instance, I heard Dr. Weaver today say that the state is going to try to put basically point-of-care antigen testing in long-term care facilities so that they can more easily monitor their residents. Mm-hmm. But at the antigen test, if those are positive, those are reportable, just like the PCR test is. But the antibody serologic test that you can go and get a blood test for, those are not reportable and therefore not in the state statistics. Now, Christine, how close did I get to the truth?
You got it exactly right. That is exactly right. I do encourage people, if you think that you had it in the past, to get that antibody test to see if you did have it and see if you have antibodies. We don't really know what that means long term to have that antibody test, but it's interesting to know. But it does not get counted in the daily case counts.
Well, Dr. Huth, I'm glad you got a question right because Christine's a very tough grader.
I know.
I think we're ready for the second question, Ryan, if you want to put it up. Has Wayne County seen any school-aged children sick with COVID-19? If so, have any of these cases been serious enough to require hospitalization?
The first part of the question, the first question of those two, is the answer is yes. Certainly. I think we've had children down to a couple of months old. I think there have been a few cases that are pretty young. And now with the testing that we're doing now, I think there's been quite a few school age and high school age children in the recent testing positives. But the other question, have any of them been in the hospital? I think I'm right in saying this. I have to go back and check. Very early on, we might have had a 13-year-old in the hospital for a day. But I think that's the youngest that we've had in the hospital. And that individual is not sick enough to stay for very long. We have had a number of 20-somethings and 30-somethings. And some of the youngest that we've had that's been sick enough to be on a ventilator was late 30s, I think I'm correct in saying. So that gives you kind of an understanding of the age spread. So there are cases that aren't very sick, that are very young, and then but the severe illness tends to be in the older age groups.
I think that's encouraging if you're a parent with young school-age children and you're debating sending your children to school. It's encouraging to hear that. What's the next question, Ryan? How many of Wayne County's 300-plus lab-confirmed positive patients have been hospitalized for COVID symptoms since the illness started?
That's a hard question for me to answer because the positives with Wayne County addresses aren't necessarily that get hospitalized aren't necessarily hospitalized at Reed.
Right.
And Reed takes cases from 9 counties. So I think it's possible Christine has more specific information about the hospitalizations among Wayne County addresses, but I don't really know what those numbers are.
And I might be able to get that. I don't have it off the top of my head, but I can go into our database and maybe I might be able to get a close
Could the two of you venture some sort of educated guess? We won't hold you to it. I know you can't come up with an exact number right now, but would you have a rough idea?
Gosh, I'm even hesitant to venture a guess.
I'm not going to venture a guess.
Because I haven't looked at the totality enough to kind of even get an impression.
Well,
it's not insignificant. We know that there have been some.
Why don't we, let's put that on the back burner. On our next show, let's try to see if we can come up with a number that's close. Do we have another question, Ryan? What restrictions, if any, are there for the prescribing of hydroxychloroquine for prevention and early treatment of COVID-19 for Indiana physicians and pharmacists?
That's interesting. The hydroxychloroquine issues kind of bubbled up, and just as a little bit of background before I get to the actual question, I think it's because there was a new prospective study published in the New England Journal of Medicine at the beginning of this week that had a negative result for hydroxychloroquine, and I know that there's a significant contingent of folks out there who are very kind of invested in hydroxychloroquine and azithromycin being a good treatment option. But the high quality studies just repeatedly are not supporting it. It's just the way it is. But the specific question to restrictions, and I think also behind that is the Ohio Board of Pharmacy actually tried to restrict it for use in COVID-19, and the governor in Ohio, DeWine, stepped in and prevented that. Here's the situation in Indiana. On the one hand, the Food and Drug Administration rescinded the emergency use authorization back about June the 15th when negative studies started to be published. But that doesn't mean doctors couldn't use it. It's just that, in fact, it has been used many, many times since then across the country. All it really means is that without the EUA, doctors certainly can use it whenever they think that it's needed, but since it's off-label, we're sort of obligated ethically to inform patients and families that we're using an off-label indication here, and that there are potential side effects. If they still want to go ahead, then, but we have to kind of involve the patient more in the decision making, about that. But there really are no restrictions on using it in Indiana. Any doctor can prescribe it for any reason. Now, on the other hand, there have been at times some supply issues, and so some organizations like hospitals and so forth have put some of their own restrictions around their prescribing, especially for prophylaxis, for prevention, because that is really a totally unexplored area, and we don't want to have a run on the hydroxychloroquine and deplete the supplies for other people who need it, like people with rheumatoid arthritis and lupus and some of the other long-term indications for hydroxychloroquine. So I've given you a long-winded answer. The basic answer is there aren't any restrictions by the state, but you can find some depending on where you're trying to get it from.
Well, you alluded to the kind of roller coaster reputation that hydroxychloroquine has had. I think this first came to our attention by a French physician that published a paper showing almost miraculous results from hydroxychloroquine. People were skeptical on the one hand because it wasn't a controlled study. Those on the other hand were saying, let's try it. And then two papers were published, one in Lancet and one in the New England Journal of Medicine by an American physician that purported that hydroxychloroquine caused cardiac arrhythmias and could potentially be fatal. But then those two papers were discredited and withdrawn. So I think there's not been any really good study to show really great effects from hydroxychloroquine. As far as I know, and Dr. Huth, correct me if I'm wrong, there's only two medicines, dexamethasone given to somebody in dire straits on a respirator, and remdesivir, which seems to shorten hospital stays. Those two drugs. Are there any other therapeutic agents that I'm not thinking about?
Not really direct pharmaceuticals. Some of the other things that had been proposed and have been tried in like clinical trials as parts of clinical research studies have been stopped. We were participating in a research study that had several arms. One of the arms was leponavir, ritonavir. I'm probably saying those wrong. Sometimes the names of these drugs I'm not that familiar with, I get wrong. But then there was also one with using an angiotensin receptor blocker. Those arms were stopped because they weren't showing benefit, and we didn't want to continue randomizing people to arms that we could already see were not going to have a benefit. The only two pharmaceuticals that have so far shown significant improvement are the remdesivir, and the federal government and the state are making Herculean efforts to get more remdesivir available and distributed to organizations. And dexamethasone, which is a corticosteroid, generally used in this context for patients who've gotten severe enough to be on a ventilator And the dexamethasone, as opposed to other corticosteroid type drugs, may have some specific benefit to reducing the inflammatory response. That's the theory. And we've been using those, and I would say we've, compared to when we were using a lot of hydroxychloroquine and azithromycin, we have better outcomes now. We feel like patients do better, get better quicker, come off the ventilator more easily. So I know that a lot of people believe in the hydroxychloroquine, and and there's lots of publications about them. It's just the quality of those studies are not great. The ones that are good are not, don't really show a lot of benefit, and our own local experience with it has not really shown much benefit that we can tell, which is disappointing. I would like to have something show fantastic benefit. We would be on it. We'd be all over that because we want to help people.
What about convalescent serum? In other words, taking, for our viewers, taking blood from a person that has had COVID and taking the serum from that patient and giving it to another patient.
That's an interesting question because we almost have the flip side situation with that. Our own experience here with convalescent serum has actually been good, we think, but we have limited numbers of patients compared to big centers. Our patients who've gotten convalescent serum, by and large, have done better, have reduced their oxygen requirements quickly after getting convalescent serum. The only and we're participating in a study that administers it as a part of a treatment arm. And on the other hand, with convalescent serum, what has been published to date has been very equivocal about whether, in general, it shows significant benefit in terms of survivorship and reduction of days on ventilator and length of stay in hospital and that kind of thing. So we like it. We're using it as a part of a clinical study if to randomize people to that treatment arm. But so far, what's been published has not really shown tremendous benefit.
And I think that this is what frustrates the public the most, is, and they forget that we're in the beginning, the infancy of this disease. And they don't understand that this is a novel virus. And so we're figuring our way out through this. And so when things come out early, like for example about the hydroxychloroquine, and that it showed good results, and then we say, well, maybe it didn't, and then we try remdesivir and we're seeing good things there, they get frustrated because they want straight answers that never change. That's what the public wants, straight answers that never change. And I try to inform them, and tell them, we know more and we do more. The more we learn about this, we're getting that information out to you. As soon as we know what that answer is, and many times the answer is, we're trying, And I remember the very first time I met you was in early March. It was a blustery Sunday morning that I got called to a meeting at Reed Health. I had to put it in my GPS because I had never even been to the hospital because I was so new here. And some of the discussions that went on that table, and that was just in March. I don't think the general public understands, when we're talking about 5 months in a novel virus, this is just the infancy. We're just getting a good look at this and how it reacts to different things. I'm really happy that the governor passed a masking mandate. I think that we will start to see in Wayne County and Indiana, the more people that we have adhering to that, a flattening of that curve and going back down to some of the numbers that we had before that. I just was in a meeting with the school where we talked about masking, and they're going to very much make children wear the mask when they're in the school. We need that also in the community. And I have been disappointed to see. I had to stop and get gas this morning on my way to work, and 0% of the people coming out of the gas station had a mask on. So,
you alluded earlier to how things have changed. You remember at the beginning we were told these particles came about 2 feet and then fell to the ground, and masks weren't needed. So we told everybody you don't need to wear a mask. And I think part of this was the CDC and the HMO were concerned that people might storm the shelves and take all the masks, and there wouldn't be any left for frontline providers. I remember at that same meeting, Tom, you told me that the Germans had published a paper where there were the Germans had published a paper where they had a patient who had transmitted the disease without having symptoms. And I remember being gobsmacked. I mean, I thought, this is not good. I mean, if you have a disease that's this infectious and you can't tell who has it by symptoms, well, that proved to be prophetic, because now we find that as many as 45% of people who have the disease and are spreading it around in society don't have any symptoms, don't know they have the disease.
That's really the challenge, isn't it? I mean, you know, I don't usually like comparisons to influenza, but I think there's a useful comparison here. You know, with influenza, if somebody gets sick, they may have a day or two or even 3 before the onset of significant symptoms when they can be spreading virus. But we don't have a situation, and then when they get sick, they usually have a lot of symptoms and, you know, immediately basically isolate themselves, because who wants to go out into the world feeling, you know, poorly from influenza?
Or when they do show up at work being Typhoid Mary, everyone avoids them.
Absolutely. But with COVID, it's just, I can't think of another condition just off the top of my head where people could be very infectious for many days prior to having symptoms, if they have symptoms at all. And so many people never get any significant symptoms, yet they can be prolific spreaders.
That's
right. And we have this new phenomenon with COVID of the super spreaders, which are people without symptoms who have very high viral loads and emit very high infectious doses around themselves. You know, very, very unique things compared to any condition we've had. And this is one of the many ways this is not your typical influenza type virus.
Well, and also a high mortality rate amongst, you know, a certain population. You know, so we're not just talking about, well, we got a disease where people get mild symptoms and then they get better, but boy, they can spread it around before they know it. That'd be great if that was all that it was.
Let's see if we have another question. Has there been any research suggesting the temperature of the water used to wash your hands makes any difference?
I am not aware of any. I think early on there was a lot of discussion about the temperature sensitivity of the virus. And that's probably where this kind of comes from. And we had seen suggestions that you should rinse your mouth with hot water several times a day and that kind of thing. I don't, you know, none of that was ever supported by any kind of evidence. I think the key thing with washing your hands is, you know, I'm not sure you can get the water hot enough to be able to wash your hands in it that would kill virus. I just don't know for sure that that's the case, because I don't know, you get the temperature much above 100 degrees and it starts getting pretty uncomfortable, right? So there's that. Plus, I think the key thing with washing your hands is just washing your hands. You know, it's more about the lipophilic effect of the soap and stuff than it is the temperature of the water. So I think, you know, if don't worry about the temperature, just wash your hands with something.
Wash your hands. In public health, we always recommend, you know, wash your hands with warm water, especially in food industries. And that has more to do with what's on the hand. But yeah, with
that
this,
probably helps to get rid of contaminants and stuff a little bit better, just by virtue of dissolving things.
I think you both got that question correct.
Good.
How much information and input has the Wayne County Health Department provided to the local school systems in preparing for reopening? I think I'm going to give this to you, Christine.
That's a great question. We have been in contact with the schools very closely through this. So the Indiana Department of Education set out guidelines for the schools and gave them really good guidance on what they should be doing to open schools up. And so they wrote their plans, and they came to the health department and said, are these right? And so we've looked at them, we've made comments back to them. It wasn't put to the health departments to approve plans, but we certainly will take a look at them and put our comments in, which we did. And then the governor, made the masking mandate, which made it easier for the schools to go from we're going to recommend wearing a mask to we're going to require wearing mask. And but we meet regularly. I just met with the superintendents of all the schools, including private schools in Wayne County, discuss some of the new things that are coming up. We're all waiting for this next week or two when the schools in Wayne County open up, and what does that look like? It's going to look very different. I don't even have kids in school, and school's going to look very different for me because normally the health department isn't in contact with the schools as much as we are. But we now have a school dashboard that the state has for local health departments. So if one of the state's case investigators identifies anyone that has to do with the school as a close contact or a positive person, it goes into this dashboard for me to look at, and then I go and I talk with the schools and make sure this child is isolated out of the school or this child is, in the quarantine period. So there's a very close connection with the schools and the health departments now throughout the state and in Wayne County.
I think so many parents are wrestling with agonizing over whether or not to send their children to school or whether to have e-learning. My children are all grown and have children of their own, but I think you have to weigh one side against the other. I think sending a child, especially a child below age 10, to school, it's pretty safe for the child. These children seem to spread the virus less than adults, and when they do get the disease, it's very mild and the school, is kind of the social fabric of society. It provides so much more than just learning, which is obviously important to these children, but for a lot of these children, it provides lunches for them and a lot of care that they're not able to get elsewhere. That particular age group, 10 and younger, are the least likely to do well with computer learning. And you just can't sit that child in front of a computer and go off to work. An adult needs to be there with the child. Older children in high school and college children, they're going to do very well with computer learning. But with the younger child, especially when you're talking about sitting there in front of a computer for 6 hours in a day, that's a daunting task for a child. On the other hand, parents are fearful that their child will have a bad experience with COVID. But I do think that the schools have put a lot of thought and work into their plan, like you said, Christine. They've done everything they possibly can to make themselves and the students as safe as they possibly can be, along with social distancing and masks.
Yeah. I have an easier conversation when I'm talking with a parent about assuring them or reassuring them that it's as safe as we possibly can make it for them to go back into school. And we do know that children, are not the ones that have the more severe. I have a harder time when I'm talking to a teacher or a bus driver that calls me and says, how am I supposed to stay safe through this? It's a difficult conversation because I understand their concerns. I get it, A lot of the teachers that have called me have some of those comorbidities, They've got diabetes or they're elderly, and, my age is starting to be elderly. And so I understand their concerns. And those are conversations that get tough.
I think we have a follow-up question to an earlier question. Can we see that, Ryan? How concerned are you about parents sending their kids to school sick, since COVID is often mild in children?
I really hope parents do the self-assessment every morning with their child. And if they have the symptoms of COVID-19, they need to keep their child home. when they have that and report it to the schools. We all have to work together in this. The parents have to be a partner with the schools have to be a partner with the parents and the students and the health departments. So it's critical. It starts at home. It's very critical. But again, I understand how hard it is for a parent who has to work to do these things. And, when it's a very mild symptom that the child is exhibiting, it is tempting to just give them a little Tylenol and send them on to school. But understanding the ramifications that come from that when we do not keep sick people home we need to take our community into consideration.
Do you think it's going to be maybe a challenge is just a switch of the mindset, even parents who have the option to keep their kids at home, they don't, maybe there's a stay-at-home mom or other caregiver at home, and they could stay home on a particular day. Under normal circumstances, little Johnny's got the sniffles today. Well, go to school. Go to school. You'll be fine. Take a handkerchief and use tissues. That would be the normal response, and nobody would bat an eye at that. But I think even minor cold type symptoms, people are going to have to say, "Well, you got to stay home today. Sorry, that's just the way it is." It's annoying, but we have to think about protecting others. It's little Johnny's probably not, if he's got COVID-19, is probably not going to be terribly sick, but we don't want him to be in a position to cause problems for others. And I wanted to mention one other thing. On today's State Department of Health provider webinar, Dr. Weaver referred to a German study, a German publication about best practices of managing kids in school, because in many European countries, they either went back to school after a period of being closed down or never closed down at all. And so a German group published some best practices, and I bring it up to give kudos to you all and the school districts around here, because the things that I've heard about that they're going to do all kind of fit squarely into the best practices that the Germans thought were worthwhile. And so I want to give kudos to you that I think whether or not we are aware of how much we're aware of best practices from other parts of the world, we've done a pretty good job of anticipating what are the right moves to make with reopening the schools.
Okay, I think we've got time for maybe one or two more questions. Can we have another question, Ryan? Can you clarify what is considered close contact?
Sure. A close contact is anyone that's been in close contact with someone that is a known COVID positive person. So that is within 6 feet of that person for longer than 15 minutes. So we talk to the schools about the importance of cohorting. And so limiting the group movement, so trying to put kids in clusters and keeping them in that, and understanding that when they get in that bubble, the more people that are allowed to come in and out of bubbles, the more kids that have to go home when Johnny gets sick. So it's within 6 feet for longer than 15 minutes. And that's cumulative 15 minutes per day.
I think we have time for maybe one more question. If I have not experienced any symptoms or felt bad, why should I go to a place to get tested where possibly sick people would be?
Well, I guess you don't have to.
No,
I think probably you should maybe think about it a little bit deeper than that. I may be feeling fine, but if I have previously been around a lot of other people, and I know that I'm going to be around other people in the future, like, in my case, I've been tested, I think 5 times so far. I've never felt bad or had a reason to do it because of any personal symptoms, but the reason that I do it is because I work clinically with, at-risk older folks in long-term care facilities, and I want to be super careful to know that I'm doing everything I can to minimize the possibility that could possibly make any of them sick.
I will tell you,
And
anytime
I
that
think that's the calculus to put into it. And so when I go to the testing site, yeah, there are other people around, but I'm not close to anybody for very long in those places. So it's the testing site I would be very surprised if we ever thought that a testing site was a source of an outbreak.
Right. That's what I was going to say is I get tested about every 2 weeks only because I know that I'm exposed a lot by having to go to meetings and things, even though I do the social distancing and I always wear my mask. I think it's important for me to know my status at all times because of my family conditions, who I have living in my house. But I would be very surprised if anyone got it from a testing site. I've been tested at the Optum site. I've also been tested at the First Care. And they take great precautions to make sure that they would not contaminate someone.
We've got about a minute left in the show. Christine, you want to say something real quick about the mask giveaway that we had?
Oh, it was very, very successful. So we had the 3 sites. Reed Health ran one, the city ran one, and the county ran one. And we gave out 300,000 masks.
Wow.
And in 3 hours. So
wow.
That was really, really good. We are looking to take it on a road show and go outside of the city limits and maybe go to Hagerstown and Fountain City and Cambridge City here coming up.
Well, that's fantastic. And you know, the people that are getting these masks are going to wear them. You know, that's what makes me so happy.
Yeah.
And that's what's going to get us through this pandemic. I mean, distancing ourselves and wearing these masks. I mean, we can have our lives back with certain restrictions. I think it's going to be a while before we are able to participate in something that requires an audience. And that's why sporting events and movie theaters, plays, symphonies, concerts, that's going to be very problematic. I think we need to mention the testing site that we have there at the Optum testing site. You have free COVID-19 testing. This is Monday through Friday, 8 a.m. to 8 p.m., 601 East Main Street, Richmond, the old Elder Beerman site. You can register online, and you can, oftentimes you can just drive in or go on in and they'll test you. I had myself tested this week and it was great. I was in and out in a very short period of time.
And you got your test results back in about 42 hours.
42. You knew that.
42.
Didn't you?
I did know that.
All right. I want to thank Jared Dunlap for taking time out of his day to be with us today. I want to thank Dr. Youth for his usual expertise, and Christine brought a whole new element, a whole new je ne sais quoi to the show. And I want to thank our audience for watching today, and I hope you can join us next Friday for another episode of Ask the Doctors. For the questions we didn't answer today, we'll get to those next week. And I want to thank John Pazzi down at Connorsville. I think I mentioned that before. And until then, I hope all of you have a great week. Be careful out there, be safe, and be well.